So my donor club today, I'm actually looking at two different articles that were published in the same New England Journal back in 2010, and both articles were evaluating rituximab use in ANCA-associated vasculitis. The first of the articles is this one, shortened RAVE trial. Really. It was a let's talk about it. So this article came out in 2010. The RAVE trial itself, and was published in New England Journal of Medicine. So as an introduction, what we know about Wegener's and microscopic polyangiitis is that they are classified as ANCA-associated vascular disease. And most patients with generalized disease have antibodies to proteinase 3 or myeloperoxidase. And also that this is a disease involving mostly small to medium-sized blood vessels and has a predilection to the kidney and respiratory tract. So for many years, the standard of care has been mostly using cyclophosphamide regimen in addition with glucocorticoids. And this has been used for years and years. We've not had any new therapy for induction in this disease for quite some time. We all know that there's big side effect profile when you combine these two medicines that have their own unique side effect. The list is endless with cyclophosphamide as well as with adding glucocorticoids. There's so many side effects with it. So people are beginning to wonder, is there anything out there that we can use that will minimize side effects and reduce exposure to cyclophosphamide therapy as much as possible? So these studies came up. Rituxan was one of the antibodies or anti-CD20 monoclonal antibody that was investigated for use and treatment or induction treatment in this disease. And the reason partly why that was done is because there's been association between B lymphocytes and the role they play in ANCA-associated disease. They are involved in making ANCAs, and people feel if you can target those lymphocytes and kind of deplete them, that there might be a response to therapy or use as induction therapy in this disease. Also, there's been several uncontrolled studies that pretty much came out mostly in the rheumatologic journals about small studies that used rituximab in ANCA disease to control or to induce remission. And those were there. There were about 2 or 3 of them before the decision to go ahead and do some of these studies came up. So rituximab in ANCA-associated vasculitis, this is a RAVE trial. Their hypothesis was that treatment with rituximab plus glucocorticoid would not be inferior to daily cyclophosphamide plus glucocorticoid for remission of induction, and would permit discontinuation of prednisone by 6 months. So that was a bold move. They wanted to remit cyclophosphamide completely and also get rid of prednisone in a regimen for induction by 6 months and see how people do. And so they did this multi-center randomized double-blind double-dummy non-inferior trial to compare this hypothesis they had. And the study was mainly targeted for 6 months. It was a 6-month study primarily because we were looking at the induction phase of treatment for ANCA-associated vasculitis. It was conducted or enrollment was from 2004 December to June 2008. And it was a sponsored study. The drug company, Genentech and Biogen, provided funding for this study. So inclusion criteria for this RAVE trial was you have to have a diagnosis of Wegener's or microscopic polyangiitis. That was the consensus definition of that. You also had to have positive PR3 or MPO ANCA. It was not just limited to newly diagnosed patients with this disease. They also had people who had previous flare-ups or who had flare-ups of previous remission disease were also allowed in this study. So it was not just only newly diagnosed disease. Their activity score was measured with the BVAS score, the Birmingham Vasculitis Activity Score. So that was what they used to measure. I don't know if some of us have seen it, but if you Google that, it's quite an exhaustive table of symptoms you could have with this disease, symptoms and signs, and they had a score for the disease. So anybody with severe enough disease to require treatment with cyclophosphamide was considered obviously somebody that could be randomized into the study. So you have to have severe enough disease that needed cyclophosphamide treatment. So some key exclusion in the RAVE trial, they did not allow people with alveolar hemorrhage severe enough to require intubation in this trial. And also serum creatinine greater than 4 in the RAVE trial was not, they didn't randomize people with serum creatinine greater than 4. So that's some key exclusions in this particular trial. And this was a treatment design. So they had the rituximab group get IV rituximab at a dose of 375 milligrams per meter squared. And this was dosed weekly for 4 weeks. And then they continued with, just so that it can be double-blinded kind of thing, they had daily placebo cyclophosphamide. So some people got, in that group, got the placebo cyclophosphamide. And then the control group got the placebo rituximab infusion with a daily oral cyclophosphamide dose of 2 milligrams per kilogram. So this was actually compared to oral cyclophosphamide, not IV cyclophosphamide. If remission occurred within 3 to 6 months, they would switch you. In the rituximab group, you were switched to placebo azothioprine because they really want to get you off. No, there was nothing for maintenance. They switched to placebo azothioprine. And then the cytoxan group were kept on the traditional azothioprine maintenance at 2 milligrams per kg. And everybody in the group, the steroid regimen is listed there. Everybody got the 1 to 3 pours of solumedrol at the dose of 1 milligram per, at a gram dose each time. And you then continued on prednisone at 1 milligram per kg per day. And the goal was to taper everybody to possibly to off by 5 months. And if there was a remission, to taper so that by 5 months all patients without remission or with remission of disease were tapered off their steroids. Now, interesting, everybody, they used PCV prophylaxis in this study. Everybody got PCV prophylaxis in the RAVE trial. So some of the things they used for assessment of disease while you were randomized, they had their disease activity scores. The BVAS obviously was the main one. They also had some physician global assessment, damage related. They assessed damage related to disease and also damage related to vasculitis itself. So they had the vasculitis damage index that was used for that. They also had this questionnaire for quality of life measure, and they abbreviated as the SF36 questionnaire, which was measuring mainly people's quality of life. They monitored all the ANCAs serially with the ELISA technique to see when they clear the ANCAs. So these are the endpoints for the study in the RAVE trial. The primary endpoint was a BVAS score of 0 and also successful completion of prednisone taper at 6 months. So we're going to get to 0 and get you off prednisone by 6 months. They actually said, I put that bullet on there, they had a non-inferiority margin that they set for their study. In other words, when you compare the two groups, to document non-inferiority in the study, you had to have at least a negative 20% point difference between remission rates in the two groups. And I'll explain more when on my further slides what that meant. In the secondary endpoints, they also looked at obviously rate of disease flares, their BVAS score at the prednisone dose that was less than 10. How many people got to 0 at prednisone? If you didn't get them off prednisone completely, how many were up to were at BVAS scores of 0 with prednisone less than 10? Also check their cumulative glucocorticoid doses that they use and rate of adverse events, as well as their quality of life measures that they also looked at as secondary endpoints. Oh, shoot. This didn't show very well, but this is the breakdown. So they had randomized, they got a total of 197 eligible patients that underwent randomization and divided them into 2 groups, with 99 in the Rituxan group and 98 in the cyclophosphamide group. Now, the breakdown of how many had Wegener's and how many had NPA is there. So if you move down the arrow on the rituximab side, 84 people in that group completed the 6 months of treatment or induction time frame. 15 of them had what some 22 early outcomes that made them, the breakdown of those outcomes below, that some were switched or had early treatment failure, and 6 had to cross over to the other side of the group. If you really look at the two groups really closely, you find out that there was similar type of crossover, similar type of, the groups were really similar in many respects. In any case, it was the intent to treat analysis, and so they included everybody, even those that crossed to the other side of each arm, that was included in the final analysis. And so the 99 were included in the analysis in the rituximab group, and 98 were included in the analysis in the cyclophosphamide group. All right. It's hard to see, but I can tell you that the main things on this is the baseline demographics, is that the mean age on this study compared to the next study I'll show you, you find that the mean age is in the 50s, 54, 51, and there were low to mid 50s for the mid age of this group. And this, I should mention that the RAVE trial was purely a North American trial in the US predominantly. And so we had all this race breakdown, as opposed to the next study I'll present, which is the RITUXIVAS trial, which was purely Europe and Australian trial, and most likely were all white. But there was a race breakdown that you can see, mostly all of them were mostly white, 90% on both sides, 95%. Their BVAS score is the right thing I want to point out down there, the degree of disease. And the BVAS score, I think, goes all the way to 67, I think. And the higher the score, the worse your degree of disease. But these were kind of on the lower end compared to the next study I'll talk about, the RITUXIVAS study. The BVAS scores here were 8.5 and 8.2. Still high, but not the high. And most of these people in this RAVE trial, nobody was dialysis dependent. So there were mostly people who had some kidney involvement, but not dialysis dependent. Yeah, so the renal involvement is shown. Most of them, about 60%, 66%, they both had some degree of renal involvement, but not enough to require dialysis. The GFR, or the creatinine clearance, as you can see, was 54 to 69. So at least there were some kidney involvement, but not enough to be on dialysis on the RAVE trial. Other things I mentioned there, I don't know if anybody noticed and can ask questions. Yeah. So the results of the study. So the primary endpoint, which, if you remember, was to get people to BVAS score of 0, and as well as get them off prednisone by 6 months, was achieved in 64% of the rituximab group, as well as on 53% of the cyclophosphamide group. Now, remember I said there had to be that minus 20 degree point difference in groups for them to say it was, that was in the target set for inferiority. So this was a plus 11%. They didn't do a study for superiority, but it was obviously more than, on the positive side, they wanted of the difference in rates of remission. And so it met the standard, the p-value of that, of being not inferior to the cyclophosphamide group. And they also looked at the percentage of remission in those that had less than 10 milligrams of prednisone a day, and that jumped from 67 to 71%. So some improvement, not too much though, with prednisone less than 10, but it went up to 71%, and then 62% in the control group. So this is what they were looking at when you look at the non-inferiority thing. This is the minus 20. So if you subtracted the rate of incidence between the Rituxan group and that of the cyclophosphamide group, you should, to be considered non-inferior, you had to be between that rate also, between the range of less than within minus 20 range. But this study had everybody about 11 and 8, depending on if you had no prednisone of 0 and prednisone of less than 10. So it still was non-inferior if you weaned off the steroid by 6 months. That's what that was showing there. Among patients with relapsing disease at baseline, this is key. Rituximab was more efficacious than cyclophosphamide. If I've gone back, let me go back just a little and show you on this table, you can see it well. But if you look at this area, people who had relapsing disease were included in this study, obviously, or who had relapsed from previous treatment. It was a there was 82% of them had been exposed to cyclophosphamide before, and in the rituximab group, those that had relapsed were treated with cyclophosphamide. 74% were treated with cyclophosphamide before, and when they finished this study, they found in that group of those who had relapsed, there was improvement or remission in their disease. 51 patients in the rituximab group, 67% reached the primary endpoint. So even after they failed cyclophosphamide and were relapsing, with rituximab, they were able to reinduce those people at that rate, 67%. When they looked at disease types, Wegener's, really not much difference, statistical difference between the groups of who responded and how the response was. 63% of people diagnosed with Wegener's responded, as opposed to 50% of cyclophosphamide. And in MPA, it was 67 and 62% response for those group of diseases particularly. Now with those with major, what they call major renal disease at baseline, now mind you, they were not on dialysis, this group, but they were significant enough in terms of their EGFR. There was no difference in the two groups as to how their response to treatment was 61 and 63% each. But of note is the fact that starting out, the baseline renal function in the Rituxan group was worse than those in the cyclophosphamide group. So starting out, there was a difference in them, but still there was no difference in the response. In alveolar hemorrhage, now mind you, those people had hemorrhage, but not enough to require intubation. But there was evidence of hemorrhage. And still, there was no difference in the response in these two groups from what they found. Now, when it came to adverse events, and that was the interesting part. Now, you would think that rituximab being not much adverse effect was initially going in, they didn't expect to see much adverse effect. But within the early phase, the 6 months of this study was for 6 months for induction, yet they found there was no difference in the total adverse events, serious adverse events, and non-disease related adverse events, as well as non-disease related, I think I put that one, events with Rituxan versus cyclophosphamide. And it was kind of surprising, but they kind of felt that the explanation they gave was possibly because 6 months was probably a short time in this RAVE trial to see some of the long-term side effects of cyclophosphamide, like infertility and all that stuff. Those things don't show up at 6 months. They probably show up down the road. But the early adverse effects that you associate with these medicines were probably the same. There was no significant difference in terms of adverse effects. So you really don't gain any benefit per se in early adverse effects with the two different medicines. They both had some significant degree of adverse effect. If you look down, this is a table showing the risk of adverse effect. Really, where I want to concentrate on is here. So if you look at all of the adverse event numbers, if you had to put a number to it, it truly was about the same for both sides. The percentage of severe adverse events from greater than grade 3 from their classification was about the same. So the list of things are up there, but the adverse effect profile really was not significantly different in the early stages within 6 months of using both medicine. In terms of death and cancer, there were 2 deaths in that 6-month period in the control group and 1 in the Rituxan group. But after this 6-month period, I think there were more deaths on the in the Cytoxan group really after the 6-month period. But there were things they had some explanations for. But in that 6-month period, they focused on, I think there was just those were the adverse effects were not really different. Now, other results that they mentioned in this well, there was no difference in both groups in the rate of both flare-ups. Severe or limited flares were about the same in both groups. No difference in the quality of life outcomes. The CD19 plus lymphocyte count obviously dropped at down in the rituximab group more than it did in the cytoxan group. It's important to know that cyclophosphamide also does affect your B cells too. but the rate of drop is much more in the Rituxan group as opposed to the cyclophosphamide group. Now they measured the time to ANCA negativity, and in the Rituxan group it occurred earlier and occurred more in the Rituxan group as opposed to the cyclophosphamide group. But the big thing is that the last line there, the rate of ANCA response was not associated with the primary endpoint. So some people still had ANCA and still had remission. And some people cleared in and prior did not respond, because there was no relation between the rate of ANCA drop or clearance with compared to remission. Now, this table shows you how the CD19 plus lymphocytes will drop off when you treat with Rituxan by the Rituxan group dropped down within the first 15 days and was down and steadily down and stayed down for 6 months. The cyclophosphamide group slowly went down and eventually got there in the 6-month period. But there was both of them had a drop, but Rituxan dropped earlier. Now, if you looked at their it's the same thing also in the log of the acid B4 cell count. There's the same drop is showing that occurred within faster in Rituxan group as opposed to cyclophosphamide group. Now, there were some limitations to the study. It only enrolled patients with severe ANCA who needed to treat with something like Cytoxan. They did not, you could extrapolate it to people with limited Wegener's disease, but it was mainly more severe folks that got enrolled here. Yeah, there was people who required ventilatory support were not enrolled in the study, and creatinine over 4 obviously was not randomized in the study. The focus of remission induction within 6 months, the focus was remission induction within 6 months, and did not address the questions of retreatment with Rituximab. And they were recommending a longer term follow-up and stuff would be needed to assess the benefit of Rituximab in this disease process. So this was their conclusion on this RAVE trial, that treatment with Rituximab and glucocorticoids is not inferior, which was what they went out to set out to look at, to the standard regimen in patients with severe ANCA-associated vasculitis. It says, moreover, the regimen may be superior to standard regimen of cyclophosphamide and glucocorticoids for remission induction in severe relapsing ANCA-associated vasculitis. So this was the RAVE in a nutshell, what they did and where they concluded and put out their statement that it was not an inferior treatment option for induction in folks with ANCA-associated vasculitis. The next I'm going to look at will be this guys, the RITUXIVAS people, and in the end I'll compare both studies and we'll look at them together. So the RITUXIVAS trial also was published in the same New England journal, and this was an European and Australian study, pretty much, and not North American study. The purpose of the trial was to assess treatment response and rates of associated severe adverse events with Rituximab-based regimen as compared with cyclophosphamide-based regimen as induction therapy in patients with recently diagnosed severe ANCA-associated vasculitis. And the hope was to have more effective and safer regimen for treatment. So they included only new diagnoses of ANCA-associated vasculitis. So no remission person was here. It was all new diagnoses. You have to have ANCA positivity to be in the study, and you have to have renal involvement as evidenced by a biopsy. So you have to have necrotizing glomerular nephritis, either through a biopsy or red cell cast, or hematuria with the red cells, 30 red cells, and high power field on your analysis. So those were the renal criteria for them there. So it was an open label 2-group parallel design randomized trial that involved 44 patients from 8 centers in Europe and Australia. They randomized people 3-to-1 as opposed to RAVE that did 1-to-1 randomization. This was a 3-to-1 randomization. It also was sponsored by a trust fund, and as well as the drug company provided a grant. And between June 2006 and 2007 was when the randomizations were done. So treatment, now in this trial, as opposed to RAVE, they allowed people to undergo plasma exchange. You could get plasma exchange or plasma pheresis before you were randomized, and also a maximum of 2 grams of IV solumetro or metroprednisolone before you were randomized. And so that was limited. Then after randomization, everybody received IV metroprednisolone at 1 gram, and then they continued with glucocorticoids at 1 milligram per kg a day, with a reduction to 5 milligram at 6 months. So this was not a goal to get to 0 at 6 months. This was a goal to get them to 5 milligrams of steroid at 6 months. And they recommended PCP prophylaxis. Not everybody got it here, but they recommended it, and also recommended fungal infection prophylaxis and osteoporosis and gastritis prophylaxis were recommended in this study. So this is a treatment they did in this Rituxivas trial. They all had the same 375 milligram per meter squared of Rituximab given weekly for 4 weeks. The difference here is that these folks here also got cyclophosphamide at a dose of 15 milligrams per kg given at the first and the third Rituximab infusion. So 2 treatments of cyclophosphamide was the protocol, but also they after treatment, they did not receive azathioprine for maintenance, so no maintenance therapy there. And they allowed for a 3rd dose of cyclophosphamide if you had some progressive disease within 6 months. Within 6 months, if you're still having some disease, they could allow for a 3rd dose of cyclophosphamide. So it was either 2 to 3 doses of cyclophosphamide, but the study was primarily for 2. Now, on the control group, which was the cyclophosphamide group, this was IV cyclophosphamide as opposed to RAVE that had oral cyclophosphamide. It was at the same dose of 15 milligrams per kg, and this was given every 2 weeks, a minimum of 6 doses and a maximum of 10 doses. And it was given until every 2 to 3 weeks actually, until there was a stable remission. That was the goal on this. I think this was published in this protocol was published in Annals of Internal Medicine back in 2009 or 2009. So they used, because one where they got this treatment pattern from, but it's published in the Annals. And then you continued with azathioprine for maintenance in the control group. So pretty much IV cyclophosphamide with maintenance after 6 months versus Rituximab with some 2 to 3 doses of cyclophosphamide allowed within 4 weeks. All right. So things they assessed and definitions they had in this study had a definition for remission, and for them remission was a BIVA score that was 0 and that was maintained for 2 months. These people had more clear definitions, it seems like, in this study. So you had to maintain it for 2 months, the BIVA score of 0, not just getting to 0. The RAVE wanted to get to 0, but this people wanted to go for 0 and maintain it for 2 months. And then you had sustained remission was felt to be a BIVA score for at least 6 months. So that was what sustained remission. Relapse, if you had a new appearance of disease or increase your BIVA score. And then progressive disease was anybody that didn't respond, pretty much persistent symptoms and things listed there, worsening symptoms. All right. Their outcomes for the study, the primary outcome was to analyze sustained remission as well as rates of severe adverse events at 12 months. So there you see that this was a 12-month study. This has gone beyond 6 months to 12 months. They were looking for people and how they did for 12 months. They also recorded deaths and malignant conditions that are called after 12 months. Those were documented, but this was primarily a 12-month study. The secondary efficacy outcomes were listed: time to remission, change in BIVA score, change in GFR, prednisone dose, and all that. Quality of life indices, and their vasculitis damage index were also kept. And then their safety secondary endpoints were serious and adverse events, infections, and death. So, all right. So this is the randomization. They had 44 patients that went randomized. And there you see that they had lesser, wasn't as much patients in this study as the other study. 33 were in the Rituxan group, and 11 were in the cyclophosphamide group on the 3-to-1 ratio. And they listed what happened to some of them. There are 6 of them died before 12 months. If you look closely, you see that most of the deaths occurred in the Rituximab group. Most of them occurred before 3 months. So these were very early deaths. 5 of the 6 died before 3 months. And the only one guy that died here died 0 months. Probably didn't get to see randomization, but died very early. And then they went ahead. The 27 were randomized, 10 randomized, and all 33 were analyzed for analysis for 12 months. So data for 12 months were collected for all this group. Now in their breakdown, these folks didn't even bother to put race, because I guess they were all white in this study, so they didn't bother to tell us which race they were. But interestingly, these were older folks. Mean age here was 68 to 67, as opposed to our guys in the RAVE trial who were in 50, low 50s. And these guys had a BVAS score that was worse. The BVAS median here was 19 and 18, as opposed to 8 and 8.5 in the other group on the RAVE trial. And yes, these people had a subgroup of dialysis-dependent population. So this was 8 here in the Rituximab group and 1 in the control group. So there were folks here who were dependent on dialysis. So this was more like these are people, you see. This was a result of their what they found. There was sustained remission occurring in 25 of 30. So when you included everybody, both those that died and were alive, there was a 76% remission in the Rituximab group, as opposed to 82% in the Cytoxin group. Now, when you remove those that died, because they died so early, and just use those that survived all through for 12 months, there was a similar rate of remission, 93% in the Rituximab group and 90% in the control group survived at 12 months, or rather had remission, sorry, at 12 months. And the median time to remission was 90 days for the Rituximab group, and then 94 days for the Cytoxin group to get to remission. Now, when they looked at the people on dialysis, which skewed up a little because most of them were in Rituximab group, 6 of the 8 people that were in Rituximab group had sustained remission, and 5 of them did not require dialysis any longer. The one patient in the control group was the guy that died. So he died before they could do much with him. So, but it was impressive that they had sustained remission even in the dialysis population who were much sicker. The adverse events here again supports what the RAVE trial found. The rituximab-based regimen was not associated with any lower rates of early severe adverse effects. So the early period, that 0 to 3 to 6 month period, mainly 0 to 3 months really, the rate of adverse effects events were similar in both the cyclophosphamide and the rituximab group. So you really won't be doing this treatment because you want to get less adverse events in those early periods. Mortality was about the same, 18% in both groups. 50% deaths were attributed to infection, and the majority of deaths occurred before 3 months. So that early period seemed like when the disease is highest and things are happening, infection and all that, you really cannot tease out any adverse effect difference between those two groups. That's what the studies show. So this is the adverse events that they listed out there, the grading of them. If you really look at the two sides, if you look at these two columns, really, if you look at the percent, just look at the percent of in brackets there, they mirror each other really. The percentages of adverse effect on both of them were the same. Thrombocytopenia is also listed there in those early periods. So they were all there, but similar. And like I said, the explanation was that they had some thinking about it because they thought some of the Cytoxan adverse effects would be further down the road because of cumulative doses of Cytoxan, as opposed to those early periods. So you might see more down the road if you have more follow-up. This was the remission, the graph showing the remission and when it happened. Within 2.5 months, or about close to 3 months, remission was almost 90% were sitting with the remission by that time. And if you looked at the adverse event, it all happened, mostly the rise was within this 3-month period. And then things kind of stabilized on both groups after that, stabilizing, but the rise was within the first 3 months for the most part. So they looked at the dose of prednisone or prednisolone that was used, and they mentioned that 96 to 89, it really wasn't different, but everybody they tried to get, by 9 months, almost everybody in both groups were down to 5 milligrams of prednisone. So we're trying to get rid of the steroids on both groups. EGFR improved about close to 20 in the rituximab group, and about 15 in the Cytoxan group. There's a little difference of 5 mils per minute in the two groups. Remission rate was about 91% in both groups, and quality of life scores were the same. Relapse was 15% in the rituximab group and 10% in the group. So pretty much no statistical difference in terms of rate of relapse in the secondary analysis. Now this was the change in the dose of prednisone. Just showed you how they tapered it down to 5. And there's some outliers, people required more, but this was prednisone dose by 12 months. Everybody was down to. So the goal in this study was to get everybody down to 5 milligrams. So they pretty much did get people down to 5. The BIVA scores also improved, and by 3 months, everybody was sitting at about 0 for those that responded. So they just highlighted that on this graph. So this conclusion for this study was that rituximab-based regimen was not superior. Again, it was not how to find superiority. It certainly was not inferior, but it was not superior to conventional cyclophosphamide regimen for induction of ANCA vasculitis. And the remission rates were high in both groups. Rituximab regimen was not associated with a reduction in early severe adverse events, and both regimes were associated with about 18% mortality. Rituximab use permits reduced exposure to cyclophosphamide and the avoidance of maintenance immunosuppression. Alright, so this was the RITUXIVAS trial in a nutshell. Now, and if you wanted to compare the difference in both groups, I kind of listed out 10 things that I could point out that were there different. Well, I did mention most of them. So, yeah, this was versus oral. RAVE was oral cyclophosphamide, and RITUXIVAS was IV Cytoxan. And you were allowed to use IV with Cytoxan with Rituxan in that group. Was 6 months, 12 months, steroid taper to 0 in 6 months in the RAVE trial, and the steroid was down to 5 milligrams at 6 months in that RITUXIVAS trial. The BIVA scores were definitely worse in the RITUXIVAS group, and EGFR, of course, was worse in the RITUXIVAS group. It was a larger trial in the RAVE study. Apheresis was allowed, or plasmapheresis was allowed in the RITUXIVAS study, but not allowed that. I guess they didn't use that for the folks in the RAVE group before randomization. I don't know what role that would have played, but that was one of the difference. And one had dialysis dependent subgroup, the other did not. And the RAVE did not have dialysis subgroup. So this was the two trials that came out and kind of looked at Rituxan. Clearly, what both of them tell you is that Rituxan is not inferior to cyclophosphamide in the induction process for treating ANCA. And even with when they were very severe, and Rituximab that had more severe people, you still had a response comparable to cyclophosphamide. And based on this trial, I think the FDA gave Rituxan an approval back, I think about 4 or 5 months ago, in the insert to be used in ANCA-associated vasculitis. So that's been given to them. So it's recommended as a form of treatment for this disease. And that's it.